Now we are going to start esophagus. First of all, anatomy. What is the length of esophagus? So length of esophagus, that is 25 centimeter. Length, it is 25 centimeter. And what is the extent? It is from C6 to T11. Clear? So length, this is 25 centimeter. And extent, that is C6 to T11. Another important point, if we perform upper GI endoscopy, on upper GI endoscopy there are 3 narrowings from upper incisor. What are the locations of those 3 narrowings? Mnemonic is BALD. How to remember? Mnemonic is BALD. B means beginning, means at cricopharynx. So this is 15, this is 25, this is 40 centimeter. So beginning, that is 15 centimeter from upper incisor, then 25 centimeter from upper incisor, and then 40. So beginning means which part? This is cricopharynx. Beginning. So this is what? Cricopharynx. A means arch of aorta and L means left bronchus. So second narrowing at the level of arch of aorta, and L means left bronchus. So this is what? Left bronchus. And D, 40 centimeter from upper incisor. So D, that is the opening in diaphragm. This is the opening in diaphragm. Clear? Now see the important characteristic features related to anatomy. You know that in esophagus there is no serosa. There is no serosa, there is no villi, no secretions. And what is the function of Meissner's plexus? Villus movement and secretion. So what happens? There is no Meissner's plexus also. There is no Meissner's plexus. So in GIT there are 2 kinds of nerve plexus. One is Auerbach plexus and the second is Meissner's plexus. So here there is only Auerbach plexus. There is no Meissner's plexus. So what is the narrowest point of esophagus? The narrowest point of esophagus, that is cricopharynx. This is the narrowest point, that is cricopharynx. And how much is the diameter? That is 1.5 centimeter. And esophagus, this is the narrowest tube of GIT. Esophagus, this is the narrowest tube of GIT. And narrowest point of esophagus, that is cricopharynx. It means any foreign body which passes cricopharynx, it is excreted in stool. So no need to remove it until and unless it's a sharp foreign body or it's a button battery. So cricopharynx, since it is the narrowest point of GIT, diameter 1.5 centimeter. This is the narrowest point of GIT. So the diameter 1.5 centimeter. Any foreign body which crosses cricopharynx can be observed, except, what are the exceptions? Except sharp foreign body, except sharp foreign body or button battery. Sharp foreign body or button battery. So we have to remove these foreign bodies. Rest, button battery. So we have to remove these foreign bodies. Rest of the foreign bodies can be observed and they are excreted in stool. Another important point, how to differentiate whether the coin is in the esophagus or coin is in the trachea. So in this image you can see that whenever the coin is in the trachea, on PA view, on chest x-ray, PA view, what we can see the edge of coin. This is what? Edge of coin. And whenever we are performing what? Lateral view, in this case you can see whenever we are performing the lateral view, on lateral view we can see the flat surface. So on lateral view we can see the flat surface whenever the coin is in the trachea. And here whenever coin is in the esophagus, you can see on chest x-ray PA view, on chest x-ray PA view we can see the flat surface. So on PA view, if it is in the esophagus, we can see the flat surface. And whenever on lateral view in esophagus, we can see the edge. We can see the edge. So it's very easy to differentiate. On PA view, if you can see the edge, it is in trachea. And on PA view, if you can see the flat surface, it's in esophagus. Second, on the basis of symptoms also you can differentiate. How? Because whenever the coin goes into trachea, what kind of symptom patient will be having? Patient will be having dyspnea. So when coin is in the trachea, patient is having dyspnea. And when coin is in the esophagus, patient will be having dysphagia. Patient will be having dysphagia. Now look at this image. This is the PA view, and on PA view, we can see the flat surface. So on the PA view, we can see the flat surface. And here you can see this is the lateral view. And on lateral view, what we can see the edge. Simultaneously, on the lateral view, you can see that this is the trachea which contains the air. It means here, where is the coin? Coin is in the esophagus. So nowadays, this is frequently asked image-based question. Congenital diaphragmatic hernia, it is of two types. One is Bogdalek hernia and the second is Morgagni hernia. See where is the defect. In Bogdalek hernia, you can see the defect is located in left posterolateral direction. So where is the defect? This is left posterolateral. It is left posterolateral. This is the defect. And if you see Morgagni hernia, here, where is the defect? Defect is right anteromedial. Here, the defect is right anteromedial. Now see the comparison. Which one is most common? Most common type, it's Bogdalek hernia. This is the most common type. That's why most of congenital diaphragmatic hernia, these are left-sided. Morgagni hernia is less common. Here, what is the most common content? And the most common content, it's transverse colon. Here, the most common content, that is transverse colon. But the most common content in Bogdalek hernia, it's small intestine. It's small intestine. So one by one we are going to discuss. First, we are going to discuss the Bogdalek hernia. So Bogdalek hernia, it is the most common type of hernia. The defect is left posterolateral. So that's why it is also known as left-sided posterolateral hernia. And what is the cause? It is caused by failure of fusion of pleuroperitoneal canal. Now what is the problem? Since there is defect in left posterolateral direction, failure of fusion of pleuroperitoneal canal, the bowel herniates from abdomen into thorax. So here question, what is the most commonly herniated organ? Most commonly herniated organ, that is small intestine. Apart from small intestine, there is herniation of stomach. There can be herniation of spleen or transverse colon. Because of herniation of these organs, you can see here, there is collapse of ipsilateral lung and there will be shift of heart towards opposite side. And what kind of abdomen here? You will find scaphoid abdomen. So it is characterized by a triad. There is respiratory distress, dextrocardia and scaphoid abdomen. So how to remember the triad? Mnemonic is RDS. The triad is RDS, that is respiratory distress, dextrocardia, scaphoid abdomen. Two important questions which are frequently asked, that is, what is the most important prognostic factor in congenital diaphragmatic hernia and what is the most common cause of death? For both, the answer is same. Most important prognostic factor as well as most common cause of death, that is pulmonary hypoplasia. This is pulmonary hypoplasia followed by pulmonary hypertension. So this is pulmonary hypoplasia followed by pulmonary hypertension. Another important point which you know, since left lung is already collapsed and stomach is there in the thorax, bag and mask ventilation, it's contraindicated. So very important point here, what? Bag and mask ventilation, it's contraindicated. Bag and mask ventilation is contraindicated. This is contraindicated in congenital diaphragmatic hernia. How we are going to make the diagnosis? We can easily make the diagnosis on the basis of chest x-ray. What is the finding on chest x-ray? Here you can see that there is presence of bowel loop in the left hemithorax. So there is presence of bowel loops. Presence of bowel loops in left hemithorax. And whenever there is herniation of stomach, you will notice that there is presence of gastric bubble. So there is presence of gastric bubble whenever there is herniation of stomach. An important point, if you are going to insert the Ryle's tube, coiling of Ryle's tube will occur in the stomach and here it is located in thorax. So you can see here coiling of Ryle's tube coiling. So coiling of Ryle's tube occurs in stomach and it is located in thorax. So you can easily make the diagnosis on the basis of chest x-ray. Now what is the treatment of hernia? Reduction of herniated organ. So reduce the herniated organ back and close the defect. So here also what's the treatment? Reduce the herniated organ back means reduction and close the defect. If large defect is there, we have to use the prosthetic patch. Why we are not using mesh? Because in children mesh should not be used. Why? Because there is growth of child but there is no growth of mesh. So Reduce the herniated organ, so reduction. What's the treatment? Reduce the herniated organ, so reduction plus closure of defect. Reduction of herniated organ plus closure of defect. Clear? Similar treatment is also done in patients who are having Morgagni hernia. So in Morgagni hernia, where is the defect? Defect is right anteromedial. So Morgagni hernia, what are the other names? It is also known as Larry's hernia, also known as retrosternal hernia because it is behind sternum, also known as right anteromedial hernia because where is the defect? Defect is right anteromedial. We discussed that via this space of Larry, this is the space of Larry, via space of Larry, superior epigastric vessels pass. So which structures are going to pass? Superior epigastric vessels. Whenever there is large defect, what is the most commonly herniated organ? We already discussed the most commonly herniated organ, that is transverse colon. So most commonly herniated organ, it is transverse colon. It is also diagnosed by X-ray, and how we treat? Reduce the herniated organ and close the defect. Very similar to congenital diaphragmatic hernia, there is a similar hernia which is common in adults, but it is acquired. And what is the name? This is hiatus hernia. So you can see here, this is the dome of diaphragm and this is the hiatus. So whenever there is herniation of only GE junction, this is known as sliding hernia. And whenever there is herniation of fundus by side of esophagus, this is known as paraesophageal hernia. So first, what are the types of hiatus hernia? Here you can see this is type 1. So type 1, other name of type 1, this is also known as sliding hernia. So type 1, since there is herniation of only GE junction, you can see here, this is known as sliding. In type 2, you can see there is herniation of fundus. So this is known as rolling hernia, also known as true paraesophageal hernia. So type 2, this is rolling hernia, also known as true paraesophageal hernia. In type 3, you can see there is herniation of both GE junction as well as fundus. Since there is herniation of both GE junction and fundus, this is mixed paraesophageal hernia. So type 3, it is mixed. Type 3, this is mixed paraesophageal hernia. Mixed. And what about type 4? You can see apart from herniation of fundus of stomach, means apart from stomach, you can see there is herniation of small intestine also. So type 4, whenever there is herniation of stomach, apart from stomach, herniation of other intra-abdominal organ. So herniation of content, in this case, herniation of content other than stomach. Content other than stomach. Other than stomach. Clear? This is type 4. Now you can easily understand the symptoms. So what is the symptom in sliding hernia? Whenever there is only sliding of GE junction, these patients have reflux. In sliding hernia, what kind of symptom? Patient is having reflux. In type 2, since there is herniation of fundus, there is paraesophageal hernia. Because of that, it can lead to ischemia, and because of this ischemia, in type 2, there is abdominal pain. In type 3, it is both what? Reflux and abdominal pain. So in type 3, there is both reflux plus abdominal pain. And in type 4, since there is herniation of organ other than stomach, there is increased risk of complication. So apart from abdominal pain, there is increased risk of complications. Risk of complications. So these are the clinical features. These are the clinical features or clinical manifestations. How to make the diagnosis? So investigation of choice for diagnosis, it is barium swallow. Investigation of choice for diagnosis, that is barium swallow. And how we are going to treat it? Just like hernia, we have to perform hiatus hernia repair via which route? Abdominal route, and it is laparoscopic repair. So what's the treatment? Treatment of choice, this is the laparoscopic hiatus hernia repair. Laparoscopic hiatus hernia repair via abdominal route. Laparoscopic hiatus hernia repair via abdominal route. Clear? This is treatment of hiatus hernia. There is another problem in patients of sliding hernia. Because of up and down movement of GE junction, what happens? There is friction. So these patients can develop ulcer where? At the lesser curvature. So there is ulcer at the lesser curvature near GE junction in which patients, the patients who are having sliding hernia. And what is the name of this ulcer? This is known as riding ulcer or Cameron's ulcer. Riding ulcers or Cameron's ulcer associated with sliding hernia location at lesser curvature near GE junction. So whenever we treat sliding hernia, this ulcer heals spontaneously. Ulcer heals spontaneously after management of sliding hernia. There is another ulcer which is asked frequently. Name is stress ulcer. Other name is stress gastritis, also known as hemorrhagic gastritis. So whenever stress ulcers are going to occur in patients of head injury, it is known as Cushing ulcer. And if it is occurring in the patients of burns, it is known as curling ulcer. So Cushing ulcers, these are going to occur in the patients of head injury. Cushing ulcer occurs in the patients of head injury, and curling ulcers, these are going to occur in patients of burns. It occurs in the patients of burns. Now, what is the most common site of stress ulcer? You know, stress ulcers are related to acid production mainly. So, what are the cells which are going to produce the acid? Parietal cells. The maximum concentration or most common site, it's fundus, followed by body, followed by antrum, followed by pylorus. So the most common site, it is fundus, followed by body, followed by antrum, followed by pylorus. And if question is asked like this, that what is the most common site in duodenum? So in duodenum, the most common site is first part, followed by second part, followed by third part, followed by fourth part. So overall, most common site of stress gastritis or stress ulcer, that is fundus. Now, see the important points related to lower esophageal sphincter. First, how much is the total length of LES? So, total length of LES, it is 5 centimeter. The total length of LES, normally, it is 5 centimeter. There is intra-abdominal length. And how much is the intra-abdominal length? This intra-abdominal length, it is 2 centimeter. And how much is the LES pressure? This LES pressure is 6 to 26 mmHg. So, here, LES pressure. LES pressure, this is 6 to 26 mmHg. This is the normal finding, okay? Normal finding. Now, what is the definition of incompetent LES? So, whenever the total length, it is less than 2 centimeter. Incompetent LES, total length less than 2 centimeter. Intra-abdominal length is less than 1 centimeter. And LES pressure, it is less than 6 mmHg. LES pressure, it is less than 6 mmHg. This is the definition of incompetent LES. So what happens? This is incompetent LES. Okay. And whenever there is incompetent LES, what will happen? The gastric content will be entering into esophagus, and this is known as what? GERD. So incompetent LES, it will lead to gastroesophageal reflux disease. It will lead to gastroesophageal reflux disease. And because of this gastroesophageal reflux disease, what will happen? First, the patients are going to develop esophagitis. So there is esophagitis. After that, what will happen? There is ulceration. After that, there is fibrosis. After that, there is stricture. So there is fibrosis, there is stricture, and you know, because of chronic injury, there can be columnar metaplasia. And what is the name of that columnar metaplasia? That is Barrett's esophagus. So because of chronic injury, there is columnar metaplasia, and that is Barrett's esophagus. Barrett's esophagus. And this Barrett's esophagus, you know, it's a pre-malignant condition. Clear? And this pre-malignant condition increases the risk of what? Adenocarcinoma. So Barrett's esophagus increases the risk of adenocarcinoma. Okay, these are the sequence of events occurring in patients of gastroesophageal reflux disease. What is the classical triad of gastroesophageal reflux disease? How to remember? Pneumonitis rara. You can see here. So pneumonic is what? Pneumonic is rara. Clear? Retrosternal heartburn, epigastric pain, and regurgitation. So these patients typically gives long history of long history of retrosternal heartburn, and generally there is short history of regurgitation. Long history of retrosternal heartburn, and there is short history of regurgitation. So how to make the diagnosis? Investigation of choice for diagnosis. Investigation of choice for diagnosis, that is 24 hours ambulatory pH monitoring. This is frequently asked question. This is 24 hours ambulatory pH monitoring. So this is 24 hours ambulatory pH monitoring. Clear? In the management, for symptomatic treatment, what we give? PPI. So for management, for symptomatic treatment, we give PPI. But what is the treatment of choice? Or I should say, what's the gold standard treatment for GERD? It is laparoscopic Nissen's fundoplication. So what's the gold standard treatment? Gold standard treatment for GERD, it is laparoscopic Nissen's fundoplication. This is laparoscopic Nissen's fundoplication. That's the gold standard. Laparoscopic Nissen's fundoplication, that's the gold standard treatment for gastroesophageal reflux disease. Now see the upper esophageal sphincter. This is the oblique fibers of thyropharyngeus. You can see oblique fibers of thyropharyngeus, and these are the transverse fibers of cricopharyngeus. In between thyropharyngeus and cricopharyngeus, there is dehiscence. And what is the name of this dehiscence? This is known as Killian's dehiscence. Just below cricopharynx, there is another dehiscence that is known as Lemmer's dehiscence. So it is just below. But if you see the area which is located below and lateral, area which is located below and lateral to cricopharynx, that is known as Killian-Jamieson area. So this location, it is located below and lateral. This is located below and lateral to cricopharynx. And Lemmer's dehiscence, it is located below cricopharynx. Below cricopharynx. So there is diverticulum, herniation of mucosa and submucosa via Killian's dehiscence. And what is the name of this diverticulum? This is known as Zenker's diverticulum. So there is herniation of mucosa and submucosa via Killian's dehiscence, that is known as Zenker's diverticulum. Since there is only herniation of mucosa and submucosa, what kind of diverticulum is this? This is false diverticulum. Zenker's diverticulum is the false diverticulum. So in esophagus, what are the diverticulum? You can see here. There is mid-esophageal diverticulum. There is epiphrenic diverticulum. Here you can see this is Zenker's diverticulum. Clear? So this one is mid-esophageal. This is mid-esophageal. It is also known as traction diverticulum. Mid-esophageal or traction diverticulum, it contains all the three layers. So this is the only true diverticulum. In esophagus, this is the only true diverticulum, that is mid-esophageal or traction diverticulum. What is the other name? Traction diverticulum. Second, Zenker's diverticulum, and this is epiphrenic. This is Zenker's diverticulum. This is epiphrenic, just above diaphragm. So Zenker's as well as epiphrenic, both of these are having only mucosa and submucosa. So these are false diverticulum. So only true diverticulum in esophagus, it is traction, also known as mid-esophageal diverticulum. So Zenker's diverticulum, it is the most common type of esophageal diverticulum. We discussed it is false because it contains only mucosa and submucosa. And in which population it is seen? More common in elderly diabetic males. Now what is the problem in patients of Zenker's diverticulum? You can see this is the diverticulum, and this diverticulum is compressing the esophagus. So diverticulum is compressing the esophagus. Because of this compression, what is the most common symptom? The most common symptom, that is dysphagia. So in Zenker's diverticulum, the most common symptom, this is dysphagia. Here it is dysphagia. Okay. One. Second, whatever the food and fluid patient is going to eat, that is going to collect in the diverticulum. After that, what will happen? There are increased risk of aspiration. So whenever there is aspiration, it leads to pneumonitis, and because of pneumonitis, there is lung abscess. So these patients are very prone for aspiration. Because of aspiration, what happens? There is pneumonitis, and because of this pneumonitis, there is lung abscess. So what is the most common complication? The most common complication, that is lung abscess. In Zenker's diverticulum, this is the most common complication. Most common complication, that is lung abscess. Second, because there is ongoing chronic inflammation, and because of that there is increased risk of squamous cell carcinoma. So ongoing chronic inflammation, because of that there is increased risk of squamous cell carcinoma. What is the investigation of choice? You can see this is the investigation. So this is what? Barium swallow. So investigation of choice for diagnosis, barium swallow. Barium swallow. Apart from those symptoms, some of the patients are having halitosis, patients are having regurgitation. So most common symptom, dysphagia, there is halitosis, regurgitation, aspiration that leads to lung abscess, that is the most common complication, and over a long period of time, it is going to increase the risk of squamous cell carcinoma. Now coming to the treatment of choice, the treatment of choice, since the patient is diabetic, elderly male, so here we go for cricopharyngeal myotomy. We perform cricopharyngeal myotomy, plus we go for diverticulopexy. So it's the cricopharyngeal myotomy plus diverticulopexy. There is another treatment option. If the diverticula is more than 4 centimeter, we can go for diverticulectomy. So another treatment, we can go for diverticulectomy. We can go for diverticulectomy. And there is a third treatment operation that is known as diverticuloesophagostomy. This is known as Dohel-Mann's procedure. So what is done here? You can see there is endoscopic stapling of septum in between. So endoscopic stapling of septum located between diverticulum and esophagus. That's why what's the name? This is also known as diverticuloesophagostomy. So Dohel-Mann's procedure, diverticuloesophagostomy. In this, what we do? Endoscopic stapling of septum located between diverticulum and esophagus. So this is diverticuloesophagostomy, also known as Dohel-Mann's procedure. Now we are going to discuss motility disorders of esophagus, and you know what is the most common motility disorder of esophagus? That is achalasia cardia, and achalasia cardia is hypomotility disorder. So most common motility disorder as well as most common hypomotility disorder of esophagus, both. In both, the answer is achalasia cardia. This is what? Achalasia cardia. And the second question, you can see most common hypermotility disorder and most painful motility disorder of esophagus. Answer is same. What? Nutcracker's esophagus. So this is what? Nutcracker's. Nutcracker's esophagus. Clear? So most common hypermotility disorder, most painful motility disorder. In both, the answer is nutcracker's esophagus. There is one thing which is common in motility disorders of esophagus. What? That the investigation of choice is same. And what is the investigation of choice for diagnosis? It is manometry. So in motility disorders, investigation of choice for diagnosis, it is same in all, and that is manometry. This is manometry. Achalasia means fail to relax. So which structure is not relaxing? That is LES. So it is characterized by absence of LES relaxation, and there is selective loss of which neurons in orbital plexus. The neurons responsible for relaxation, these are inhibitory neurons. So there is selective loss of inhibitory neurons. It is caused by selective loss of inhibitory neurons. There are two types of achalasia. One is primary achalasia and the second is secondary or pseudoachalasia. Pseudoachalasia, it is secondary to known causes like malignancy and Chagas disease. So what are the types? It is of two types. First, primary achalasia, and the second is secondary achalasia. Secondary achalasia, it is also known as pseudoachalasia. It is because of known causes like malignancy, or Chagas disease. Chagas disease. What is the problem in achalasia cardia? You can see this is the esophagus and this is the stomach. So this is the LES which is not relaxing. So what will happen? Whatever the food and fluid patient has taken, that will be collected into esophagus. So every food stuff, liquid, drink, everything will be collected into esophagus. So the most common symptom, dysphagia. Since nothing is going into stomach, what is the second most common? Weight loss. So clinical features. Here, most common symptom in achalasia cardia, the most common symptom, it is dysphagia followed by weight loss. It's a characteristic symptom. Dysphagia followed by weight loss. Now, what kind of dysphagia? This dysphagia is more to liquids as compared to solids. And this is a pointer, it's a clue for the diagnosis. This dysphagia, you have to highlight this dysphagia, it is more to liquids followed by solids. But what happens in rest of the cases, in majority of other cases, dysphagia is more to solids followed by liquids. But here, dysphagia is more to liquids followed by solids. So there is dysphagia, there is regurgitation, there is weight loss. This is the triad of achalasia cardia. So what's the triad? It is DRA. How to remember? Mnemonic is DRA. That is dysphagia, regurgitation, and weight loss. We discussed Zenker's diverticulum, and in Zenker's diverticulum also there was collection of food and fluid. Here, whole esophagus is filled with food and fluid. Because of that, here also there is increased risk of aspiration. So here also what happens? There is aspiration. Since there is aspiration, what will happen in these patients? Pneumonitis. And because of this pneumonitis, what else is going to occur? Patients are going to develop lung abscess. So here also, what is the most common complication? In achalasia cardia also, the most common complication, that is lung abscess, and it increases the risk of squamous cell carcinoma. So there is increased risk of squamous cell carcinoma, and the most common complication, that is lung abscess. We already discussed what is the investigation of choice, and investigation of choice for diagnosis. We already discussed investigation of choice for diagnosis, that is manometry. It is manometry. There are characteristic signs which are seen on barium swallow. So you can see here, this is known as bird beak, also known as pencil tip, also known as rat tail appearance. So here you can see bird beak, rat tail or pencil tip appearance. This is seen on barium swallow. There is rat tail filling defect. Rat tail filling defect, it is seen in carcinoma esophagus. But rat tail appearance, it is seen in achalasia cardia. So bird beak appearance, pencil tip appearance, rat tail appearance on barium swallow. In achalasia cardia, LES is not relaxing, so we can give drugs for relaxation. Which drugs? We can give calcium channel blockers, we can give nitrates. Calcium channel blockers or nitrates. Second option, we can go for Botox injection, or we can go for bougie or balloon dilatation. But what is the treatment of choice? The treatment of choice is laparoscopic Heller's cardiomyotomy. So treatment of choice, that is laparoscopic Heller's cardiomyotomy, which is also known as Heller's operation. Laparoscopic Heller's cardiomyotomy. Cardiomyotomy. This is also known as Heller's operation. There is another treatment which is done, another treatment, and what's the name of that another treatment? This is known as POEM. So POEM is also done for achalasia cardia, and the full form of POEM, per oral endoscopic myotomy. So this is what per oral, the name is per oral endoscopic myotomy. So this is per oral endoscopic myotomy. This is the treatment. And some patients who are having massively dilated esophagus, so you can see this is massively dilated esophagus, it is looking like sigmoid colon. So this is known as sigmoid esophagus. Massively dilated esophagus in chronic cases, which is also known as sigmoid esophagus. So what is the treatment for this condition? The treatment is esophagectomy. So if patient is having sigmoid esophagus, in these cases the treatment is esophagectomy. Next condition is diffuse esophageal spasm. This is because of tertiary contraction, and you know that this tertiary contraction is spasmodic contraction. So what happens in this case? There is spasm in the esophagus, and because of spasm, what will happen? The esophagus blood supply is temporarily cut off. So what happens? It leads to spasm, and it is going to impair the vascular supply temporarily, and because of that, what will happen? There is ischemia, and because of that ischemia, what is the symptom? Patients are going to develop chest pain. So obviously which side? Left sided, because esophagus is located on left side. So left sided chest pain. And what else? Patients are going to develop dysphagia. So there is chest pain and dysphagia. Investigation of choice is same, just like any other motility disorder. So investigation of choice for diagnosis, that is manometry. This is manometry. There are characteristic appearances which are seen on which investigation barium swallow. What are the appearances? So in the image you can see that on barium swallow there is corkscrew appearance. On barium swallow there is corkscrew appearance, also known as rosary bead appearance, also known as pseudo diverticular appearance. Corkscrew appearance, rosary bead appearance, also known as pseudo diverticular appearance. These are the characteristic appearances which are asked in exam. Characteristic appearances. Almost every year it's asked in the form of image based question. Clear? How to treat it? So here we have to give antispasmodics. So mainly we give calcium channel blockers, in some cases nitrates. So for the treatment, what is given? For the treatment, mainly we give antispasmodics. So main treatment is calcium channel blockers. Sometimes we have to give nitrates. In non-responding patients, we have to go for esophagomyotomy. So if patient is not responding, in that case, esophagomyotomy. Esophagomyotomy is done. Next is nutcracker's esophagus. That is the most common hypermotility disorder. This is most painful motility disorder. And here also the patients are having chest pain and dysphagia. So here also the patients are having chest pain and dysphagia. And how we are going to make the diagnosis? Here also diagnosis is made by manometry. So investigation of choice for diagnosis, that is manometry. Manometry. And in this case, what's the treatment? We have to give antispasmodics. So generally for the treatment we use what? Calcium channel blockers, sometimes nitrates. Calcium channel blockers, sometimes nitrates. Usually surgery is not having significant role, so it is managed by calcium channel blockers and nitrates. See this image. Here you can see this is pale squamous epithelium, and in between you can see there is tongue like projection. So this is the tongue like projection, which is red velvety mucosa. And what is this red velvety mucosa? This is the columnar epithelium. So this is columnar epithelium. Okay, so you can see that in lower part of esophagus, some part of squamous epithelium, it is replaced by columnar epithelium. So this is known as columnar metaplasia. And what is the name of this columnar metaplasia? This is Barrett's esophagus. So you know that in Barrett's esophagus, what is there? There is columnar metaplasia. This is characterized by columnar metaplasia. And what kind of columnar metaplasia is there? You know, it is intestinal metaplasia. So what kind of columnar metaplasia? There is intestinal metaplasia. And in intestinal metaplasia, you know that there is presence of goblet cells also. So intestinal metaplasia, it is characterized by what? Presence of goblet cells. Presence of goblet cells. We discussed what's the risk factor for Barrett's esophagus. So chronic reflux. And you know, chronic reflux occurs in GERD also, and it occurs in sliding hernia also. So what's the cause? What is the cause of Barrett's esophagus? So Barrett's esophagus is caused by chronic reflux because of GERD, gastroesophageal reflux disease, or it also occurs because of sliding hernia. Because of sliding hernia. So obviously the patients will be having signs and symptoms of what? Reflux. So patients will be having clinical features of reflux. How we make the diagnosis? So first, this kind of appearance should be there. Means tongue like projection. There should be red velvety mucosa. So how we are going to detect it? By endoscopy. By endoscopy. And second, for confirmation there should be presence of goblet cells, then only it is intestinal metaplasia. So how you can detect the goblet cells? Biopsy. So investigation of choice for diagnosis of Barrett's esophagus, endoscopy plus biopsy. And you know, even for carcinoma esophagus, investigation of choice for diagnosis, that is endoscopy with biopsy. Here patient is having symptoms of reflux, so obviously the treatment is similar to GERD. So we have to treat it like GERD, and every 1 to 2 year, what we have to go for? We have to go for endoscopy with biopsy. So endoscopy plus biopsy should be done every 1 to 2 years. And why we should perform endoscopy with biopsy every 1 to 2 years? To rule out adenocarcinoma. Why? To rule out adenocarcinoma. Because it's a risk factor for adenocarcinoma. Now in detail we are going to discuss carcinoma esophagus. So what is the most common type of carcinoma esophagus worldwide? Most common worldwide, it is squamous cell carcinoma. And if you see the western countries, most common type in western countries, that is adenocarcinoma. Most common type in western country, that is adenocarcinoma. Another important point, what is the most common site of squamous cell carcinoma? So squamous cell carcinoma, the most common site, it is middle one third. This is middle one third. And what is the most common site of adenocarcinoma? This is lower one third. This is lower one third. And if nothing is mentioned in exam, only straightforward question is asked, that overall most common site of carcinoma esophagus. So overall most common site of carcinoma esophagus, that is middle one third. Now see the risk factors. For squamous cell carcinoma, risk factors are different. For adenocarcinoma, risk factors are different. Usually squamous cell carcinoma is more common in low socioeconomic status, and adenocarcinoma, it is more common in high socioeconomic status. So see the risk factors for carcinoma esophagus. First of all, see what are the risk factors for squamous cell carcinoma. So first, alcohol and smoking. Second, Zenker's diverticulum, and we discussed what? Achalasia cardia. Zenker's diverticulum as well as achalasia cardia, both of these are going to increase the risk of squamous cell carcinoma. After that, intake of nitrites, nitrosamines. So intake of nitrites, nitrates and nitrosamines. These are going to increase the risk of squamous cell carcinoma. Fungal toxins, Plummer-Vinson syndrome, it increases the risk of squamous cell carcinoma of oral cavity, hypopharynx as well as esophagus. Hot liquid ingestion, caustic injuries means acid or alkali. So accidental intake of acid or alkali. Or if there is Tylosis palmaris et plantaris, some patients who have deficiency of what? MOSA. What's the mnemonic? MOSA. Mo means molybdenum. This is molybdenum. Z means zinc and A means vitamin A. Molybdenum, zinc, vitamin A. In the latest exam, this question was asked that which vitamin deficiency increases the risk of squamous cell carcinoma? Vitamin A deficiency. And another risk is bulimia nervosa. So all these are the risk factors for squamous cell carcinoma. In adenocarcinoma, you will notice that most of the risk factors are revolving around GERD. So first, GERD. Second, if patient is taking high fat diet, so obviously high fat diet as well as obesity, both of these are going to increase the risk of adenocarcinoma. Scleroderma, which is characterized by smooth muscle atrophy. So in scleroderma also, there is increased risk of GERD, and Barrett's esophagus is a pre-malignant condition and it increases the risk of adenocarcinoma. So these are the risk factors. In carcinoma esophagus, what is the most common site of metastasis? So you know that in all GI malignancies having hematogenous spread from esophagus till rectum, most common site of metastasis, that is liver. So the most common site of metastasis, it is liver. Chemotherapy regimen, it is ECF. What is the chemotherapy regimen? This is ECF and full form epirubicin, cisplatin, 5-fluorouracil, and you know that the same chemotherapy, it is given in carcinoma stomach also. So the same chemotherapy, it is given in esophagus as well as carcinoma stomach. So it is given in esophagus as well as carcinoma stomach. Now what is the problem in carcinoma esophagus? You can see this is the growth. This kind of growth is there in the lumen. Because of this kind of growth, what will happen? There is luminal obstruction. So since there is growth in the lumen, it leads to what? Luminal obstruction. And whenever there is luminal obstruction in esophagus, obviously it will lead to what? Dysphagia. So most common symptom in carcinoma esophagus, that is dysphagia. And what kind of dysphagia? Since there is growth going inside the lumen, there is progressive dysphagia. So actually speaking, this is progressive dysphagia. So the most common symptom, it is dysphagia followed by weight loss. And what kind of symptom? There is progressive dysphagia. Progressive dysphagia means initially dysphagia is for solids. Initially it is solids followed by semi-solids followed by liquids. So initially dysphagia is for solids followed by semi-solids followed by liquids. One problem. Second problem, sometimes this malignancy, it is going to penetrate the wall, and after that it is going to communicate with trachea. And if it communicates with trachea, what will happen? There is formation of tracheoesophageal fistula. So any patient who develops what? This tracheoesophageal fistula. Suppose a patient develops tracheoesophageal fistula. So what are the manifestations? These patients are going to develop choking, coughing, cyanosis and dyspnea. So another problem, patients might develop tracheoesophageal fistula, and because of tracheoesophageal fistula, there is choking, coughing, cyanosis and dyspnea. What is the first investigation done in a suspected case of carcinoma esophagus? That is barium swallow. And what is the typical appearance seen? On barium swallow, this is the typical appearance known as apple core appearance. So here you can see this is the lumen and this is the malignancy. This is the malignancy. Obviously, the part of esophagus which is patent, in that part only barium is going. So this appearance is known as what? Apple core appearance. And you know, this apple core appearance is non-specific. It means it is also seen in carcinoma colon. But the investigation is different. In carcinoma colon, apple core appearance, it is seen on barium enema. And in carcinoma esophagus, it is seen on barium swallow. So see the important investigations which are done. We discussed first investigation done in a suspected case of carcinoma esophagus, that is barium swallow. First investigation done, that is barium swallow. But what is the investigation of choice for diagnosis? Investigation of choice for diagnosis of carcinoma esophagus, it is endoscopy with biopsy. An investigation of choice for staging of both carcinoma esophagus as well as carcinoma stomach, that is endoscopic ultrasound. So investigation of choice for staging, that is endoscopic ultrasound, and it is same in carcinoma esophagus as well as carcinoma stomach. Problem, whenever the malignancy is outside the lumen, so if there is advanced malignancy or there is luminal obstruction, it's very difficult for you to perform endoscopic ultrasound. So whenever there is advanced malignancy or there is luminal obstruction, in these cases for staging we are going for CCT. So in these cases for staging we go for CCT. And whenever there is distant metastasis, so for distant metastasis we go for PET scan. Investigation of choice for distant metastasis, we go for PET scan. Now, treatment of carcinoma esophagus, we perform esophagectomy. And simple question, how much margin we take during esophagectomy? During esophagectomy, we take 10 centimeter margin. In some tumors, we go for definitive chemoradiation. And definitive chemoradiation, it is given for squamous cell carcinoma of cervical esophagus and GE junction tumors which are not amenable to resection. So for which tumors? Squamous cell carcinoma of cervical esophagus, squamous cell carcinoma of cervical esophagus, and GE junction tumors. GE junction tumors not amenable for resection. Not amenable to resection. Clear? Not amenable to resection. Okay. So one important principle, in any GI malignancy, if we go for resection and anastomosis, how much margin we take? We take 5 centimeter proximal and 5 centimeter distal margin. So in GI malignancies, we take 5 centimeter margin. But there are two exceptions. One, esophagus. In esophagus, how much margin we take? We saw that in esophagus, we take 10 centimeter margin. So first exception, it is esophagus, 10 centimeter margin, and the second exception is distal rectum. So in GI malignancies, how much margin we take? Important point. In GI malignancies, during resection and anastomosis, how much margin we take? We take 5 centimeter margin. We take 5 centimeter margin. So what are the exceptions? Exceptions are first esophagus. So we discussed that in esophagus we take 10 centimeter margin, and in distal rectum, and how much margin we take in distal rectum? Yes, in distal rectum we take how much? 2 centimeter margin. 2 centimeter margin. So let's discuss all the questions related to margin whenever we are performing wide local excision for squamous cell carcinoma, basal cell carcinoma, malignant melanoma and soft tissue sarcoma. In all these cases, how much margin we take? We take 2 centimeter margin. So during wide local excision of squamous cell carcinoma, basal cell carcinoma, malignant melanoma and soft tissue sarcoma, we take margin of 2 centimeter. Another important point, whenever we are performing breast conservation surgery, during breast conservation surgery for wide local excision, we take how much margin? 1 centimeter. So important point, if we perform breast conservation surgery, during breast conservation surgery for wide local excision, how much margin we take? 1 centimeter. So you saw that in majority of non-GI malignancies, 2 centimeter margin is taken. In GI malignancies, 5 centimeter margin is taken. Two exceptions, esophagus 10 centimeter, distal rectum 2 centimeter, and during breast conservation surgery, we take 1 centimeter margin during wide local excision. What are the types of esophagectomy performed for carcinoma esophagus? First is Ivor-Lewis operation, second is Oringer transhiatal esophagectomy, and the third is McKeown en-bloc esophagectomy. So out of these three, which one is most popular? The most popular is Oringer transhiatal esophagectomy. So this is most popular. This is most popular. Clear? And what about McKeown en-bloc esophagectomy? Here, dissection is performed under direct vision by thoracotomy. Since dissection is performed under direct vision, that's why here it is associated with least recurrence rate. So most popular, that is Oringer, and having least recurrence rate, that is McKeown en-bloc esophagectomy. Now in this image you can see this is the tumor. So we perform esophagectomy, and after performing esophagectomy, what? This is the stomach. So this stomach is pulled up, and here we perform the esophagogastric anastomosis. So at the site of esophagus, we are using what? Stomach. So this is the conduit. So this is what? Conduit. So simple question, what is the best conduit after esophagectomy? And the best conduit is stomach, followed by left colon, followed by jejunum. So replacement conduit after esophagectomy, which one is best? Best is stomach, followed by left colon, followed by jejunum. Then questions are asked that these are based on which artery. So this stomach is based on right gastric and right gastroepiploic artery. So it is based on right gastric artery plus right gastroepiploic artery. So right gastric and right gastroepiploic artery. Left colon, obviously it is based on left colic artery, and you know that left colic artery, it's a branch of inferior mesenteric artery. So left colon, it is branch of left colic artery, and this left colic artery, it is a branch of inferior mesenteric artery. Inferior mesenteric artery. Then jejunum. Jejunum is the branch of jejunal branches of superior mesenteric artery. So jejunum, it is based on jejunal branches. It is based on jejunal branches of superior mesenteric artery. Clear? So these are the replacement conduits. Best is stomach, which is based on right gastric artery plus right gastroepiploic artery. What is the shortest and most preferred route of replacement for esophagus? And it's the same route where esophagus passes. So this is which one? Posterior mediastinal route. Posterior mediastinal route. This is the shortest and most preferred route. Posterior mediastinal route. Clear? Now, what is the preferred treatment for malignant tracheoesophageal fistula? So, if patient is having malignant tracheoesophageal fistula, in that case, here you can see what we are inserting. We are inserting the stent. So, if patient is having malignant tracheoesophageal fistula, we are inserting the stent. This is SIMS, self-expanding metallic stent. So, what's the name of this stent? It is SIMS. This is SIMS. This is self-expanding metallic stent. This is self-expanding metallic stent. Clear? So self-expanding metallic stent for malignant tracheoesophageal fistula. This is the preferred treatment. See the prognostic factors for carcinoma esophagus. We discussed that in most of the malignancies, most important prognostic factor it is stage. Why? Because stage contains TNM. Stage contains TNM, and in carcinoma esophagus, stage mainly depends on the depth of invasion. So here, single most important prognostic factor, that is depth of invasion. Second is number of involved lymph node, and third is location of tumor. Now which tumors has having better prognosis? Cervical tumors and GE junction tumors are having better prognosis than thoracic tumor. So location of tumor, which tumors? Cervical tumor, cervical and GE junction tumors. Cervical tumors and GE junction tumors, these are having better prognosis. These are having better prognosis than thoracic tumors. Clear? So you can see the importance of location. But the most important is depth of invasion. Other important risk factors are number of involved lymph nodes and location of tumor. Next is leiomyoma. You know, it's the most common benign tumor of esophagus. And what is the location? In 90% of the cases, it is located in lower two-third. In 90% of cases, it is located in lower two-third of esophagus. It is more common in males. Here you can see the tumor. This is the tumor and this is the leiomyoma. Clear? So what happens? Initially patient is asymptomatic, but slowly when the size of leiomyoma keeps on increasing, it is going to compromise the lumen. And if it is going to compromise the lumen of esophagus, obviously what patient is going to develop? Chest pain and dysphagia. So because of luminal obstruction, what happens? See the clinical features. Initially patients are asymptomatic. But because of this luminal obstruction, obviously if obstruction is there in esophagus, what? Patient is having dysphagia, and patient develops chest pain. So there is dysphagia and chest pain. You know what is the investigation of choice here? Investigation of choice for diagnosis, it's barium swallow. So investigation of choice for diagnosis, that's barium swallow. And you know that this is benign tumor, right? And in benign tumor, what you can go for? I can easily go for enucleation. So in this case, since it's a benign tumor, I can go for enucleation. So enucleation can be done. So what is the treatment of choice here? The treatment of choice for leiomyoma, that is enucleation. Treatment of choice for leiomyoma, it's enucleation. Sometimes there is image-based question related to leiomyoma and they ask you what is the typical appearance on barium swallow. So here you can see there is punched out filling defect. So on barium swallow, what kind of typical appearance is there? There is punched out filling defect. Punched out filling defect. Next condition is Plummer-Vinson syndrome. You know, the other name is Patterson-Brown-Kelly syndrome, and it is also known as sideropenic dysphagia. Why sideropenic dysphagia? Because this patient is having iron deficiency anemia. So sideropenic. And why dysphagia? Because these patients are having upper esophageal web. So dysphagia, why? Because patients are having upper esophageal web. Upper esophageal web. There is another question which we already discussed, that it is a pre-malignant condition and it increases the risk of what? It increases the risk of squamous cell carcinoma. Squamous cell carcinoma of what? Oral cavity. Increases the risk of squamous cell carcinoma of oral cavity. Then hypopharynx as well as esophagus. Hypopharynx as well as esophagus. Clear? It's a pre-malignant condition. Plummer-Vinson syndrome, it is characterized by splenomegaly, achlorhydria, dysphagia. Why there is dysphagia? Because we discussed there is upper esophageal web. So dysphagia, it is because of upper esophageal web. There is chronic iron deficiency anemia, atrophic oral mucosa, or patients are having glossitis. Atrophic oral mucosa or glossitis, and koilonychia means spoon-shaped nails. So how to remember? Mnemonic is SAD, CA, coil. Mnemonic Mnemonic is SAD, CA coil. Clear? S, splenomegaly. A, achlorhydria. D, dysphagia. C, A, chronic iron deficiency anemia, atrophic oral mucosa or glossitis, and there is chylonychia. What is dysphagia lusoria? Lusoria means anomalous course of artery. Lusoria, it means anomalous course of artery. So if there is anomalous or abnormal course of artery, that abnormal course of artery is responsible for dysphagia, that is known as dysphagia lusoria. It is responsible for dysphagia, that is known as dysphagia lusoria. Now see what is the problem here. There is arteria lusoria. What is that arteria lusoria? You can see here. There is aberrant right subclavian artery. Ideally, the right subclavian artery arises from brachiocephalic. Brachiocephalic gives rise to right common carotid and right subclavian. But this aberrant right subclavian artery arises from arch of aorta. After that, you can see here, it is going to take U-turn and it is going towards right side. So what happens? This is the esophagus and this structure is trachea. So this anomalous or aberrant right subclavian artery, this aberrant right subclavian artery, it is going to cause posterior compression of esophagus, and this is causing dysphagia. So dysphagia lusoria, what is the most common abnormality? In dysphagia lusoria, the most common abnormality, and that is what? Aberrant right subclavian artery, which is arising from arch of aorta, and it leads to posterior compression. It leads to posterior compression of esophagus. So this is dysphagia lusoria, leads to posterior compression of esophagus. Clear? So this is dysphagia lusoria. Now you can see this is Schatzki's region, and here there is concentric symmetric narrowing. It is characterized by concentric symmetric narrowing. Clear? And this concentric symmetric narrowing, it is composed of what? Here you can see this ring, it is composed of mucosa and submucosa. So this ring is composed of mucosa and submucosa. It leads to concentric symmetric narrowing. Because of this, what will happen? There is restricted distensibility. And if it leads to restricted distensibility, obviously patient will be having dysphagia. So there is restricted distensibility, and because of this, patient will be having what? Dysphagia. But here, dysphagia is seen only for the solid foods. Only for the solid foods there is dysphagia. And whenever patient is having large piece of mutton or large piece of chicken, so what happens? There is large piece of chicken and mutton. It is going to cause intermittent obstruction, and it leads to episodic aphasia. So typical symptom in these patients that there can be episodic aphasia. Another symptom is episodic aphasia. So there is dysphagia for solid foods, only, and there is episodic aphasia. If you see the typical location, it is located at squamo-columnar junction. So what is the location? This is located at squamo-columnar junction. This is Schatzki's ring. What is the investigation of choice for diagnosis? You can see here, investigation of choice for diagnosis, it is barium swallow. It is barium swallow. This is barium swallow. Clear? Imagine a patient who is asymptomatic and it was incidentally detected, no treatment. So if patient is asymptomatic, diagnosed incidentally. So asymptomatic patient and it was detected incidentally, what? No treatment. No treatment. But if patient is symptomatic, in that case we can go for dilatation. Surgical excision should not be done. Why? Because if you are going for surgical excision, it can cause stricture. So dilatation is done for symptomatic patients. For symptomatic patients, we go for dilatation. Surgical excision should not be done. Why surgical excision should not be done? Because it leads to stricture. So surgical excision can cause stricture. That's why it's not done. What's the treatment for symptomatic patients? Dilatation. What is the most common cause of esophageal perforation? And you know, it is iatrogenic. So most common cause of esophageal perforation, this is iatrogenic. Means during which investigation? It is During which investigation? It occurs during endoscopy. So iatrogenic, it occurs during endoscopy. Now, whenever we are performing endoscopy, you can see what is the most common site of perforation, cricopharynx, and which wall is the posterior wall of cricopharynx. So the most common site of perforation, that is posterior wall of cricopharynx. This is posterior wall of cricopharynx. This is posterior wall of cricopharynx. Next is Boerhaave syndrome. This is spontaneous esophageal perforation. So what is the most common site of perforation? You can see here. In patients of forceful vomiting, repeated vomiting, the most common site of perforation is this. So this is the site of perforation. It is the lower one-third along left posterolateral direction. So the most common site, it's lower one-third. This is lower one-third along left posterolateral direction. Left posterolateral direction. So lower one-third along left posterolateral direction. So what will happen whenever there is forceful vomiting, repeated vomiting, the gastric content or vomitus, it enters into thorax or mediastinum. When it is going to enter into thorax, especially in the mediastinum, patient will develop severe mediastinitis. So it is characterized by a triad known as Mackler's triad. What are the components? Thoracic pain, vomiting, and cervical subcutaneous emphysema. So Boerhaave syndrome, it is characterized by Mackler's triad. Components are thoracic pain, vomiting, cervical subcutaneous emphysema. What are the investigations done? If we perform chest X-ray, there is hydropneumothorax. On chest X-ray, there is hydropneumothorax. But what is the investigation of choice here? We are using water-soluble contrast. So name of investigation, it's water-soluble contrast esophagogram. So name of investigation, investigation of choice for diagnosis, that is water-soluble contrast esophagogram. So water-soluble contrast esophagogram. Clear? Contrast esophagogram. Now you tell me which water soluble contrast we use. So most commonly we are using gastrographin and the second is Hypec. So if we are using gastrographin that is preferred. Second option we can use Hypec. Clear? Now the treatment depends on the presentation. Within how many hours patient presented to you? If patient presents within 24 hours, that's the golden period of repair. So if patient presents within 24 hours, this is the golden period of repair. Here we repair the perforation. We insert ICD. Why? Because there was mediastinitis, the gastric content entered into thorax, and we perform feeding jejunostomy. Since it's golden period of repair, mortality, it is up to 20%. So mortality is up to 20% if patient comes within 24 hours. If patient comes after 24 hours, here after 24 hours tissues become friable, so we cannot perform the repair and we go for esophagostomy. We perform insertion of ICD and feeding jejunostomy. If patient comes after 24 hours, mortality is more than 50%. So golden period of repair, that is within 24 hours. So this is all about esophagus. Now we are going to start the stomach. First, see the anatomy of stomach. So here you can see this is cardia. And what is the important point? Cardia is the most common site of Mallory-Weiss syndrome. So this is cardia. This is cardia. And cardia, it is the most common site of Mallory-Weiss syndrome. Most common site of Mallory-Weiss syndrome. Second, you can see this is angle of His. So this is angle of His. Okay. After that, you can see this. This is fundus. Fundus. So what are the important questions related to fundus? You know, fundus is the most common site of stress gastritis or stress ulcer. So first, it is most common site of stress gastritis or stress ulcer. And this is the most common site of carcinoma stomach in pernicious anemia. So this is most common site of carcinoma stomach in pernicious anemia. Carcinoma stomach in pernicious anemia. After that, you can see this. This is body. This is body. And what is the important point related to body? This is the location of interstitial cells of Kejal. So here, gastric pacemaker is located. So in the body, there is location of gastric pacemaker, and that is interstitial cells of Kejal. And you know, exact location is in the body, in the mid body along greater curvature. So exact location in the mid body along greater curvature. After that, this is antrum. So here you can see this is antrum. And what is the question related to antrum? You know, antrum is the most common site of carcinoma stomach. So overall, antrum, this is the most common site of carcinoma stomach. After that, this is pylorus. So you can see this part, this is pylorus, and over lesser curvature, this is incisura angularis. This is known as incisura angularis. And what is the important point related to incisura angularis? This is the most common site of gastric ulcer. So incisura angularis, this is the most common site of gastric ulcer. So these are the questions related to anatomy and one-liner questions which are asked frequently in relation to stomach. Now we are going to discuss the vagotomy. You know that in most of the peptic ulcers, what happens? There is increased acid production. So for faster healing of ulcer, we have to decrease the acid production. And you know that vagus is going to increase the acid production. So if you perform vagotomy, it helps in faster healing of ulcer. How? Because it is going to decrease the acid production. So what are the types of vagotomy? Highly selective, selective and truncal vagotomy. So which one is having maximum morbidity and minimum recurrence? So truncal vagotomy, this one is having maximum morbidity. So it is associated with maximum morbidity, but there is minimum recurrence. So maximum morbidity, but minimum recurrence. And what about highly selective vagotomy? This one is having minimum morbidity. There is minimum morbidity but maximum recurrence. So there is minimum morbidity but maximum recurrence in highly selective vagotomy. Clear? So there is one question which is asked frequently. What is the treatment of choice for intractable duodenal ulcer? Intractable means it is not healing after medical management. And for intractable duodenal ulcer, we go for highly selective vagotomy. Treatment of choice, highly selective vagotomy. And if patient is having recurrent duodenal ulcer, so what? We don't want further recurrence. So for recurrent duodenal ulcer, we go for truncal vagotomy. So important questions: intractable duodenal ulcer, highly selective vagotomy should be done, and for recurrent duodenal ulcer, truncal vagotomy should be done. Peptic ulcer includes both duodenal ulcer and gastric ulcer. And which one is more common? Duodenal ulcer, this is more common than gastric ulcer. So what is the most common type of peptic ulcer? The most common type of peptic ulcer, that is duodenal ulcer. Next, what is the most common site of peptic ulcer? So in duodenum, which site? It is first part of duodenum. So most common site, this is first part of duodenum. First part of duodenum. Now there is one important point related to peptic ulcer. What? That the treatment of gastric ulcer, it depends on the location. Why? Because location is variable. And in duodenal ulcer, since the location is fixed, treatment depends on the complication. So to understand the management of gastric ulcer, first you should know that what's the classification for gastric ulcer, and there is modified Johnson's classification. Now see the modified Johnson's classification for gastric ulcer. In type 1, there is ulcer at incisura angularis. So here you can see ulcer is located at incisura. It is located at incisura angularis. In type 2, there are two ulcers. You can see here, one in body, and one in first part of duodenum. One in body and one in first part of duodenum. In type 3, this ulcer is pre-pyloric, just before pylorus. So this is pre-pyloric. Pre-pyloric. In type 4, you can see ulcer is located where? High on lesser curvature. So in type 4, there is ulcer located high on lesser curvature. Located high on lesser curvature. And after that, type 5, anywhere which is NSAIDs induced. Out of these 5 types, obviously, what is the most common type? Usually in classifications, if classification starts from 1, 2, 3, 4, 5, usually most common type is type 1. And if it starts from A, B, C, D, E, most common type, type A. So here, what is the most common type? Most common type, it's type 1. Type 1, that is most common. Second, if you see all these from type 2 to type 5, all these are associated with blood group O. But type 1, this is associated with blood group A. If we see type 1, 4, 5, if we see type 1, type 4 and type 5, in all these cases, the acid production is either normal or it's decreased. So acid production, it's either normal or it's decreased. But in type 2 and type 3, in type 2 and in type 3, there is increased acid production. There is increased acid production or there is hypersecretion of acid. Clear? It means in type 2 and type 3, we have to perform vagotomy. Why? Because we want to decrease the acid production. That's why what's the treatment in type 2 and type 3? Here you can see in type 2 and type 3, we perform truncal vagotomy plus antrectomy. So for type 2 and type 3, it's the truncal vagotomy plus antrectomy. What should be done for type 1? For type 1, we perform distal gastrectomy. For type 1, we perform distal gastrectomy. In type 4, ulcer is located high on lesser curvature. So here, some special procedure is performed. So here, special surgeries or special procedures are performed in which we are going to excise the ulcer locally. And for type 5, management is easy. What? Stop NSAIDs. So for type 5, stop NSAIDs. So for type 2 and type 3, since there is increased acid production, what we have to perform? Truncal vagotomy plus antrectomy. Truncal vagotomy plus antrectomy. Clear? So here you saw that treatment of gastric ulcer, it depends on the location. Now the treatment of duodenal ulcer, it depends on the complication. So first understand what are the complications of peptic ulcer. So first is intractability, or there is intractable duodenal ulcer, and we already discussed that for intractable duodenal ulcer, what is the treatment of choice? Highly selective vagotomy. So for intractable duodenal ulcer, we go for highly selective vagotomy. Bleeding is the most common complication of peptic ulcer. Bleeding, this is the most common complication. This is the most common complication of peptic ulcer. Peptic ulcer. Clear? So how to remember? This is BP. Bleeding is the most common complication of peptic ulcer. Perforation, this is the most common complication of gastric ulcer. So perforation, this is most common complication. Most common complication of gastric ulcer. Clear? So here, how to remember? It is PG. Perforation, most common complication of gastric ulcer. So bleeding, peptic ulcer. Perforation, gastric ulcer. So how to remember? BP taken by PG. BP taken by PG. Bleeding, peptic ulcer. Perforation, gastric ulcer. Gastric outlet obstruction, this is rare. It's a rare complication of peptic ulcer. Now see, the ulcer can be located on the anterior wall or posterior wall of first part of duodenum. You know that anteriorly located ulcers perforate and posteriorly located ulcers bleed. Why? Because there is one artery here. Can you tell me what is the name of this artery? So this is gastroduodenal artery. Name of this artery, this is gastroduodenal. And after that, it gives superior pancreaticoduodenal, and this is right gastroepiploic. So this is right gastroepiploic artery, and this is superior pancreaticoduodenal. So one question which is frequently asked, that what is the most commonly involved artery responsible for bleeding in duodenal ulcer? So for bleeding duodenal ulcer, which artery is responsible? Gastroduodenal artery. This is responsible for bleeding duodenal ulcer. So this is responsible for bleeding duodenal ulcer. Another important point, anteriorly located ulcers perforate. Anteriorly located ulcers perforate and posteriorly located ulcers bleed. Posteriorly located ulcers bleed. So what should be the treatment in bleeding duodenal ulcer? When patient is having bleeding duodenal ulcer, we have to perform the duodenotomy. So you have to open the duodenum. After that, you have to ligate the bleeding vessel. After that, we have to perform what? Truncal vagotomy. And then we have to perform pyloroplasty. So what is the treatment here? In bleeding duodenal ulcer, we perform duodenotomy. After that, you go inside the lumen. Then perform ligation of bleeding vessel. So duodenotomy with ligation of bleeding vessel. To prevent recurrence in future, we perform truncal vagotomy, and to prevent stricture, we perform pyloroplasty. So this is the treatment for bleeding duodenal ulcer. And whenever there is perforation, we perform omental patch repair, that is also known as modified Graham's repair. So here you can see there is duodenal ulcer perforation since it is located on anterior wall, and you know that anteriorly located ulcers perforate. So here what we perform omental patch repair. Here you can see we are performing omental patch repair. And what is the other name of this omental patch repair? It is also known as modified Graham's repair. This is also known as modified Graham's repair. So this is omental patch repair, also known as modified Graham's repair. What we do, we are going to patch the perforation with vascularized pedicle of omentum. Gastric outlet obstruction because of peptic ulcer, it is rare. That's why what is the most common cause of gastric outlet obstruction worldwide? It is not peptic ulcer, it is carcinoma stomach. So it is not peptic ulcer, it is actually carcinoma stomach. Now, what is the most common site of gastric outlet obstruction in peptic ulcer? So you know the most common site of peptic ulcer, that is first part of duodenum, and at the first part of duodenum only sometimes there is inflammatory edema or stricture. So it is first part of duodenum. This is first part of duodenum. So first part of duodenum. How we are going to make the diagnosis of gastric outlet obstruction? The diagnosis is made by saline load test. It is made by saline load test. Most of the patients are managed conservatively. When the patient is NPO, we give IV fluids, we perform gastric lavage, and majority of patients are going to improve within 48 hours. Whenever we are giving IV fluids, what is the fluid of choice? Fluid of choice, that is normal saline. Fluid of choice in gastric outlet obstruction as well as in hypertrophic pyloric stenosis, that is normal saline. Now imagine if patient is not improving. In such cases, what we perform? Truncal vagotomy. And what we perform antrectomy. So we perform truncal vagotomy and antrectomy. So for non-responding patients, the treatment of choice, that is truncal vagotomy plus antrectomy. Some patients are having extensive fibrosis or scarring near antrum or near first part of duodenum. So whenever there is extensive fibrosis or scarring, and if antrectomy is difficult, in those cases alternative treatment is truncal vagotomy plus gastrojejunostomy. So truncal vagotomy plus gastrojejunostomy, this is alternative treatment. This is alternative treatment. Who performed first gastrectomy? It was performed by Billroth. So first gastrectomy, it was performed by Billroth in 1881. There are two types of gastrectomy. One is Billroth 1 and the second is Billroth 2, depending upon the method of reconstruction. Now see how we are going to do it. You can see this is the stomach and this is the duodenum. Clear? I'm going to perform what? Gastrectomy. So this part of stomach was removed. After that we are left with only this part. So this is the proximal part of stomach which is left, and we are going to attach the duodenum. So this is known as Billroth 1. Billroth 1. So here you can see the stomach is directly attached to duodenum. So what should be the other name? The other name of this surgery should be gastroduodenostomy. So Billroth 1, this is gastroduodenostomy. This is gastroduodenostomy. Clear? And second is Billroth 2. Here you can see this is the proximal part of stomach. And now we are going to attach jejunum like this. So if I'm going to attach the jejunum, you can see here, this is loop gastrojejunostomy. Clear? So this is what? Billroth 2. This is known as Billroth 2. This is Billroth 2. And what should be the other name of Billroth 2? It is loop gastrojejunostomy. This is loop gastrojejunostomy. So you can see Billroth 1 is more physiological because food content enters into stomach then goes into duodenum. And in Billroth 2, food enters into stomach first and later immediately it is going to enter into jejunum. That's why most of the complications are seen in Billroth 2. So Billroth 1 more physiological, maximum risk of complications are occurring in Billroth 2. So what happens in dumping syndrome? There are constellation of symptoms because of accelerated emptying or dumping of hyperosmolar content where into the proximal part of small intestine. And we discussed it is obviously more common in Billroth 2. So dumping syndrome, it is more common in Billroth 2 as compared to Billroth 1. So what are the differences? There are two types of dumping syndrome. One is early dumping and second is late dumping. See the differences? Early dumping usually seen within 15 to 30 minutes of meals. Why? Because the hyperosmolar content enters into jejunum, and because of that what will happen? It is going to attract too much of secretion and the fluid is collected into proximal part of jejunum. So what happens within 15 to 30 minutes of meals, there is hyperosmolar content into jejunum, and because of that there is increased secretion, and because of that patient develops hypovolemia. So how to manage early dumping? Since patient is having hypovolemia, we have to give IV fluids. So here the management is we have to give IV fluids to the patient. What happens in late dumping? It is seen after 2 to 3 hours of meals, and it is because of reactive hypoglycemia. Why? Because hyperglycemic content is there in jejunum, and because of that there is increased insulin which leads to reactive hypoglycemia. So late dumping, it occurs after 2 to 3 hours of meals because of hyperglycemic content in jejunum. And what you have to remember, there is reactive hypoglycemia because of increased insulin release. So two questions. Question is asked, what is the cause of early dumping? Hypovolemia. What is the cause of late dumping? Reactive hypoglycemia. And any patient who is having hypoglycemia, what's the management? We have to give oral glucose. So in such cases, we have to give oral glucose. So this is dumping syndrome. Now see the metabolic complications of gastrectomy. What is the most common metabolic complication of gastrectomy? This is iron deficiency anemia. The most common metabolic complication, this is iron deficiency anemia. And whenever more than 50% of stomach is removed, these patients develop megaloblastic anemia. Why these patients are going to develop megaloblastic anemia? Because of absence or decreased intrinsic factor when more than 50% of stomach is removed. So most common metabolic complication, iron deficiency anemia, and when more than 50% of stomach is removed, then megaloblastic anemia. What is the most common cause of upper GI bleeding? And that is peptic ulcer. Most common cause of upper GI bleeding, that is peptic ulcer. Clear? What is the first investigation done in upper GI bleeding? And you know, the first investigation done, that is endoscopy. So first investigation done in upper GI bleeding, that is endoscopy. Clear? Whenever we are performing endoscopy, first we are going to assess that where is the site. So what's the site of bleeding? Second, we have to assess that how much is the risk of rebleeding in future. Means you are going to assess the site and to detect the risk of rebleeding by endoscopy. So here, this is known as Forrest classification, in which we estimate the rebleeding risk based on endoscopic findings. So Forrest classification, it is used for estimation of risk of rebleeding. Estimation of risk of rebleeding based on endoscopic finding. Rebleeding based on endoscopic finding. So based on endoscopy. Clear? Now see, according to Forrest classification, what are the types? 1A. 1A is active pulsatile bleeding. 1B, when there is oozing, but you can't see the source of bleeding. 2A, there is non-bleeding visible vessel. 2B, at the site of bleeding, there is adherent clot. 2C, there is black dot. And 3, there is clean base, no evidence of bleeding. So what? Which of the following is having high risk of rebleeding? There is high risk of rebleeding in type 1A, 1B, 2A. There is high risk of rebleeding. There is intermediate risk of rebleeding in 2B. So here there is intermediate risk, and there is low risk of bleeding in 2C and 3. So in 2C and 3 there is low risk. Now we are going to discuss the bleeding disorders of stomach. And in all bleeding disorders of stomach, obviously there will be bleeding. So what is the investigation of choice? In all of these, the investigation of choice is common, that is endoscopy. So first we are going to discuss Mallory-Weiss syndrome. Mallory-Weiss syndrome, it is characterized by longitudinal partial tear. Longitudinal partial tear. So here you can see there is involvement of only mucosa plus submucosa. So that's why it's a partial tear. It is characterized by longitudinal partial tear involving mucosa and submucosa. And what is the most common site? Most common site, it's cardia. Means what is the location? It is located just below GE junction. So most common location, cardia, located just below GE junction. It is more common in alcoholic males and it occurs because of multiple vomitings, forceful vomiting, retching. What is the good thing? That this condition is painless. It is painless, and in majority of cases there is minor bleeding. What happens? But in 20% cases there is massive bleeding. Only in 20% cases there is massive bleeding. Otherwise, in majority of cases there is minor bleeding. One thing we already discussed, that in all bleeding disorders of stomach, investigation of choice is same. So what? Here also investigation of choice for diagnosis, that is endoscopy. So investigation of choice for diagnosis, that is endoscopy. Since in majority of cases bleeding is minor, it stops on its own. So what we go for? Conservative management. If bleeding is not going to stop, then we go for endoscopy with electrocoagulation. If it is not available or failed, we can go for angiography with embolization. If it's also not available or failed, then we go for open surgical ligation. So the management, initially conservative management, because most conditions or in most cases the bleeding is minor, it stops spontaneously. If it is not going to improve, then endoscopy with electrocoagulation. If it is not available or failed, then angiography with embolization. And if it's not available or failed, we perform laparotomy and we go for open surgical ligation of bleeding vessel in Mallory-Weiss syndrome. Question is asked that what is the artery responsible for bleeding? And you can see this artery is responsible. So which artery is going to supply this particular area? This is left gastric artery. You know, left gastric artery is the largest artery supplying the stomach. So most common artery responsible for bleeding, most common artery responsible for bleeding, that is left gastric artery. In this case it is left gastric artery. What is Dialfoy's lesion? So you can see here there is presence of large arteriole. There is presence of large arteriole which is placed just below mucosa. Presence of large arteriole placed just below mucosa, diameter 1 to 3 mm, located within 6 to 10 centimeter of GE junction. What is the problem? Basically, because of gastric environment and because of the pulsation, overlying mucosa is lost. And whenever overlying mucosa is necrosed because of continuous pulsation, yes, acid is going to work on the wall of this arteriole. And because of that, you can see here what kind of bleeding is going to occur. Here you can see active pulsatile bleeding is going to occur. So in this case, it leads to active pulsatile bleeding. And since there is active pulsatile bleeding, it leads to hypotension. So there is active pulsatile bleeding. So actually it leads to massive bleeding. So it leads to massive bleeding, and these patients are also having hypotension, recurrent hypotension. So initially there is massive bleeding and patients are having recurrent hypotension. So massive bleeding and recurrent hypotension. Clear? Now, you know already that investigation of choice for diagnosis is same. Investigation of choice for diagnosis, that is endoscopy. And here management is similar. What we do first, we go for endoscopy with electrocoagulation. If it is not available or failed, angiography with embolization. And if that is also not available or failed, we go for open surgical ligation. This is watermelon stomach. What is the other name? GAVE. GAVE means gastric antral vascular ectasia. So here you can see on endoscopy, there are parallel stripes of vessels. And these parallel stripes of vessels, it is looking like what? Rind or covering of watermelon. That's why it is known as watermelon stomach. What is the full form of GAVE? Gastric antral vascular ectasia. So what is the most common site? The most common site, it is antrum. most common site, that is antrum. And what is the pathology? Vascular ectasia. So pathology, patient is having vascular ectasia. Usually this watermelon stomach, it is more common in elderly females. So because of this vascular ectasia, what happens? These patients are having chronic occult bleeding. So it leads to chronic occult bleeding. And if patient is having chronic occult bleeding, it leads to what? Anemia. And because of anemia, what is the symptom? Symptom is fatigue. So because of anemia, the symptom is fatigue. But this is chronic occult bleeding. Here also, diagnosis is same. Diagnosis, investigation of choice for diagnosis, it is endoscopy. And what you can see, parallel types of vessels. But you have to confirm the vascular ectasia also. And for that, you have to do the biopsy. So here, what is the investigation of choice for diagnosis? So you can see, we perform endoscopy plus we have to do biopsy. Why? Because we have to confirm the vascular ectasia. And the treatment is also easy. When you perform endoscopy, what we perform in the treatment? Endoscopy plus electrocoagulation. So we perform what? Endoscopy plus electrocoagulation. So this is how we manage GAVE or watermelon stomach. Now we are going to discuss carcinoma stomach, and the most common histological type of carcinoma stomach, that is adenocarcinoma. So histological type, it is adenocarcinoma. You know that most of the adenocarcinomas are common in high socioeconomic status, but carcinoma stomach, this is an exception. Carcinoma stomach is more common in low socioeconomic status. And you know, in low socioeconomic status, there is low fat and low protein intake. That's why here in carcinoma stomach, low fat and low protein intake, it's a risk factor. So see the list of risk factors for carcinoma stomach. So first is nutritional risk factor. So low fat and low protein intake, high complex carbohydrate intake, and if there is increased intake of nitrates, all these are the nutritional risk factors. After that, social risk factor. So it is more common in low socioeconomic status. So social risk factor, it is more common in low socioeconomic status. After that, environmental risk factors, it is more common in smokers. So it is more common in smokers, and lack of refrigeration increases the risk. Why? Because whenever we preserve food and water in refrigerator, what happens? H. pylori gets killed. So lack of refrigeration increases the risk. If we are using well water which is contaminated with H. pylori, or if there is poor food preservation technique, all these are environmental risk factors. Now see the medical risk factors. What happens if partial gastrectomy has been done? Patient is having infection with H. pylori, or patient is having Epstein-Barr virus infection, patients who are having adenomatous polyp, or patient is having chronic atrophic gastritis, Menetrius disease, all of these are going to increase the risk of carcinoma stomach. After that, occupational risk factors. So in which particular occupation there is increased risk? Occupational risk factors. So it is more common in rubber and coal workers. Carcinoma stomach, it is more common in rubber and coal workers. It is more common in rubber and coal workers. After that, have a look of genetic factors. First, carcinoma stomach, it is more common in male gender. In blood group A, HNPCC, hereditary non-polyposis colorectal cancer increases the risk. Apart from that, Li-Fraumeni syndrome and pernicious anemia, all of these are going to increase the risk of carcinoma stomach. Very important point which you have to remember, what? Alcohol is not a risk factor. For carcinoma stomach, alcohol is not a risk factor. It's not a risk factor. In relation to carcinoma stomach, there are two classifications which are asked. One is Borman's classification and the second is Lawrence classification. Now see, in Borman's classification, what is type 1? Here you can see there is diffuse polypoidal growth. So if there is diffuse polypoidal growth, that is type 1. Whenever there is ulcerated lesion with raised borders, ulcerated lesion with raised borders, that is type 2. Here, ulcerated lesion which is infiltrating the gastric wall. So ulcerated lesion infiltrating the gastric wall, this is what? Type 3. And you can see type 4. Type 4 is Linitis plastica. What happens in Linitis plastica? There is leather bottle stomach. So there is extensive fibrosis in submucosa. So type 4, this is Linitis plastica. Linitis plastica. Clear? And whenever it cannot be classified in any of these four, that is type 5. So type 1, diffuse polypoidal growth. Type 2, ulcerated lesion with raised borders. Type 3, ulcerated lesion infiltrating the gastric wall. Type 4, Linitis plastica. And type 5, which is non-classifiable. So this is Borman's classification. It's a pathological classification. Now see the Lawrence classification. So how to remember Lawrence classification? It's very easy. There are two types. One is intestinal variety and the second is diffuse variety. How to remember? Intestinal variety is the classical variety. What do you mean by classical variety? You know, in majority of cases of carcinoma stomach, patients are males. So it is more common in males. Age group around 60. What is the most common site? Antrum or distal part. And what kind of risk factors are there? Environmental risk factors. There is well-defined gland formation. What kind of route of spread is there? Hematogenous. So intestinal variety, it is classical variety. Diffuse variety, it is atypical. Atypical means seen in young patients, seen in females, most common site proximal part. What kind of risk factors? There is familial risk factors and there is lymphatic or transmural spread. So see the differences. So intestinal variety is the classical variety. How to remember? This is classical variety and diffuse variety, it is atypical variety. This is atypical variety. So classical variety, intestinal variety, more common in males, more common in elderly, age around 60. What is the most common site? Is the distal part. Most common site is distal part. What are the risk factors here? Environmental risk factors. Environmental risk factors. Clear? In this case, there is well-defined gland formation and there is hematogenous spread. What is the gene mutation? Here, there is APC gene mutation. In intestinal variety, there is APC gene mutation and it is epidemic. Means it is scattered throughout the world. Epidemic. Now see the diffuse variety. So diffuse variety, more common in females, more common in young patients, and the most common site is the proximal part. Here, the most common site, that is proximal part. And what are the risk factors? What kind of risk factors? There are familial risk factors. Familial risk factors. Poor gland formation. So what kind of variety you can see? Signet ring variety. Poor gland formation. Here we can see signet ring variety. Signet ring variety is seen. Here there is lymphatic or transmural spread. What is the mutation which is asked here? It is decreased E-cadherin. And this is endemic. Endemic means it is clustered in certain areas. There is one similarity between intestinal variety and diffuse variety. What? That one of the mutation is same. Which one? In both of these, there is inactivation of P16 and P53. So both of these are associated with what? Inactivation. Both of these are associated with inactivation of P16 and P53. So this is common in intestinal variety and in the diffuse variety. So maximum incidence of carcinoma stomach, it is seen in which country? It is seen in Japan. And we discussed already that carcinoma stomach, it is more common in what? Males. And in which particular age group it is seen? It is seen in 6th decade. So more common in males, seen in 6th decade. Clear? What is the most common site? We discussed the most common site of carcinoma stomach, that is antrum. What is the most common site in pernicious anemia? That is fundus. So most common site in pernicious anemia, fundus. And you know, in all GI malignancies having hematogenous spread, most common site of metastasis, that is liver. It is liver. Chemotherapy regimen, it is same for carcinoma esophagus and carcinoma stomach. And what is the regimen? ECF. It is ECF. So full form, epirubicin, cisplatin and 5-fluorouracil, and we discussed it is same for both carcinoma esophagus. It is same for carcinoma esophagus as well as carcinoma stomach. Same for carcinoma esophagus and stomach. Now see the clinical features. What is the most common site of carcinoma stomach? The most common site is antrum. And whenever growth is at antrum, what will happen? There is obstruction, and because of this obstruction, what is the most common symptom? It is abdominal pain followed by weight loss. But if patient is having GE junction tumor, imagine patient is having tumor at this GE junction. So if there is GE junction tumor, what is the most common symptom? Here, there is dysphagia. So for GE junction tumor, the most common symptom, it is dysphagia. And if it is located at antrum, so overall most common symptom, that is abdominal pain. It is abdominal pain. So most common symptom in carcinoma stomach, that is abdominal pain followed by weight loss. This is abdominal pain followed by weight loss. And for GE junction tumors, most common symptom, here the most common symptom, it is dysphagia. GE junction tumors, the most common symptom, it's dysphagia. And nowadays you will notice that what? The incidence of GE junction tumors is rising. There is another tumor you can see. What? This is Linitis plastica, also known as leather bottle stomach. So in Linitis plastica, there is extensive fibrosis in submucosa. And because of this extensive fibrosis in submucosa, stomach loses the property of distensibility. So Linitis plastica, what is the other name? This is also known as leather bottle stomach. This is known as leather bottle stomach. And what is the most common symptom of Linitis plastica or leather bottle stomach? Here, patient develops early satiety. Patient develops early satiety. Why? Because stomach loses the property of distensibility. Now see the important points related to lymph node involvement in carcinoma stomach. Whenever there is involvement of left axillary lymph node, this is known as Irish nodes. Involvement of left axillary lymph node, that is Irish nodes. Whenever there is involvement of left supraclavicular lymph node, this is known as Troisier sign. And what is the name of lymph node? This is known as Virchow's node. So name of lymph node, this is Virchow's node. Lymph node, it is Virchow's node. And what is the name of this sign? This is known as Troisier sign. Name of sign, Troisier sign. And name of lymph node, that is Virchow's node. Another important point, sometimes in patients of carcinoma stomach, there is cutaneous metastatic deposit. This is not lymph node. This is metastatic deposit. Where exactly? Around umbilicus. This is known as Sister Mary Joseph node. This is known as Sister Mary Joseph node. Cutaneous metastatic deposit around umbilicus. Sister Mary Joseph node. And if we perform digital rectal examination, there is palpable intraperitoneal metastasis, and that is known as what? Blummer's shelf. So palpable intraperitoneal metastasis on digital rectal examination, that is Blummer's shelf. There is another question which is asked frequently, what Krukenberg tumor? So in carcinoma stomach, there is involvement of bilateral ovary, and that is what? That is Krukenberg tumor. Involvement of bilateral ovary. Involvement of bilateral ovary, that is known as Krukenberg tumor. So in Krukenberg tumor, there is involvement of bilateral ovary. Bilateral ovary. Now, what is the route? Most commonly, it is involved by retrograde lymphatic route. So most common route, you have to remember, this is via retrograde lymphatic route. Most commonly, it is via retrograde lymphatic route. What are the other routes? This is most common. It can be involved, means the ovaries can be involved because of transcoelomic transperitoneal route. It can be involved because of hematogenous route, but most commonly it is retrograde lymphatic. You have to be very careful because previously the most common route was thought to be transcoelomic transperitoneal, but at present it is retrograde lymphatic. So for Krukenberg tumor, it is retrograde lymphatic route. Now coming to the diagnosis, what is the investigation of choice for diagnosis? It is same like carcinoma esophagus, endoscopy plus biopsy. Investigation of choice for staging, same like carcinoma esophagus, what? Endoscopic, ultrasound. So investigation of choice for diagnosis, that is endoscopy plus biopsy. Investigation of choice for staging, same like esophagus, endoscopic, ultrasound. Best investigation for pre-operative staging, and this is CCT. For pre-operative staging, the best investigation, that is CCT. Now see the treatment of carcinoma stomach. The treatment depends on the location. So whether malignancy is located in proximal 1/3, it is located in middle 1/3, or it is located in distal 1/3. Imagine it is located in proximal one-third. So whenever malignancy is located in proximal one-third, we go for what? Extended gastrectomy. So if malignancy is located in proximal one-third, we go for extended gastrectomy. And apart from extended gastrectomy, we perform D2 lymphadenectomy. So this is extended gastrectomy plus D2 lymphadenectomy. Clear? Here we remove stomach and some part of esophagus. Whenever malignancy is located in the middle one-third, here we go for total gastrectomy. So if it is located in middle one-third, we go for total gastrectomy. And apart from total gastrectomy, what else is done? We have to go for D2 lymphadenectomy. So total gastrectomy plus D2 lymphadenectomy. D2 lymphadenectomy. And whenever malignancy is located in distal one-third here, so distal one-third, we perform subtotal gastrectomy plus D2 lymphadenectomy. So here the treatment is subtotal gastrectomy plus D2 lymphadenectomy. We perform D2 lymphadenectomy. Clear? So the same treatment will be there for both intestinal variety and diffuse variety with one exception. What is that exception? If the diffuse variety, it is involving what? Distal one-third. At the place of subtotal gastrectomy, we should perform what? Total gastrectomy. Rest is same. So if patient is having diffuse variety, we should not leave some part of stomach. So in distal part, whenever malignancy is there and it is diffuse variety, we perform total gastrectomy plus D2 lymphadenectomy. So this is how we manage patients of carcinoma stomach. Now we are going to discuss very important tumor, that is GIST, gastrointestinal stromal tumor. So that is GIST. How to remember most of the important features of GIST. Very important point is what? This one, stromal. So this is gastrointestinal stromal tumor, means it is arising from stroma or it is arising from mesenchymal tissues. So mesenchymal origin is there or stromal origin is there. It means it behaves like what? Sarcoma. This tumor behaves like sarcoma. So what is the most common route of spread in sarcomas? Yes, there is hematogenous spread. So in this case also, there is exclusively hematogenous spread. In sarcomas, usually there is no lymphatic spread. So in GIST also, there is no lymphatic spread. Third, here we are not supposed to take 5 centimeter margin. How much margin will be sufficient here? 2 centimeter, just like treatment of sarcomas in which we perform wide local excision with 2 centimeter margin. So what you have to remember, it is stromal tumor. So there is stromal origin or mesenchymal origin. Now question, what is the most common site? So the most common site is stomach, followed by small intestine, followed by colon rectum, followed by esophagus. Colon rectum followed by esophagus. You know that GIST arises from gastric pacemaker cell, also known as interstitial cells of Kejal. So it arises from ICC cells, interstitial cells of Kejal, that is interstitial cells of Kejal, also known as gastric pacemaker cell. You know the tumor is going to express tyrosine kinase receptor. And what is that tyrosine kinase receptor? It's a question. The receptor is c-KIT. And there is a marker for this receptor. And what is that marker? That is CD117. So apart from this marker, what are the other markers which are important in GIST? So one is CD117, second is BCL2, third CD34, and the fourth marker, that is PDGFR alpha, that is platelet derived growth factor receptor alpha. There are two new markers, one is DOG1 and the second is protein kinase C theta. The new markers, DOG1, full form of DOG1, detected on GIST1. So this is DOG1 detected on GIST1 and the second is protein kinase C theta. These are the markers. Now coming to the types, what are the types? One is spindle cell variety and second is epithelioid. So spindle cell and epithelioid, which one is more common? It is spindle cell. So spindle cell variety, it is more common. This is responsible for 70% cases, and epithelioid, this is responsible for 30% cases of GIST. Now, what kind of growth pattern is there in the tumor? You can see this is the growth pattern in the tumor. So this tumor is having extraluminal growth. We discussed carcinoma stomach. Carcinoma stomach was having intraluminal growth. That's why this patient was symptomatic at early stage. But what happens? Just these patients are symptomatic at advanced stage until and unless patient is going to have bleeding. Why? Because the tumor is highly vascular. So when tumor bleeds, presentation is bleeding and abdominal pain. So what is the most common symptom? Patient presents with bleeding and abdominal pain. So there is bleeding and abdominal pain. And we already discussed that it behaves like sarcoma. So most common route of spread, that is hematogenous, and lymphatic spread is not seen. The route of spread, that is hematogenous, lymphatic spread is not seen, and most common site of metastasis, liver. So important point which you have to remember here, lymphatic spread is not seen. Lymphatic spread, it is not seen. This is not seen. Clear? Now, how to make the diagnosis? Since the tumor growth is outside the lumen, here we should not get anything, or we are not getting anything by endoscopy. So, what is the investigation of choice for diagnosis? Here, the investigation of choice for diagnosis, that is CCT. In GIST, investigation of choice for diagnosis, it is CCT. Now, what kind of treatment should be done? It behaves like sarcoma, so we go for what? This kind of resection, and this is what? Segmental resection. So it is segmental resection or wedge shaped resection. So in the treatment, whenever there is resectable tumor, we go for segmental resection or wedge shaped resection. Treatment is segmental resection, segmental or wedge shaped resection. And how much margin we take? 2 centimeter. So segmental or wedge shaped resection, and we take 2 centimeter margin with 2 centimeter margin. Now imagine the tumor is unresectable, so we have to downstage the tumor. And for downstaging the tumor, what is the first line agent? Imatinib mesylate. Second line agent, sunitinib. And the third line agent, that is regorafenib. So drug of choice for unresectable GIST, that is imatinib mesylate. This is imatinib mesylate. Second line agent means drug of choice for imatinib resistant GIST, we give sunitinib. We give sunitinib. And third line agent, there is a new drug, regorafenib. Regorafenib. So how you are going to check whether patient is responding to imatinib or not? So for assessing the response of therapy, what we go for? PET scan. So for assessing response of therapy to imatinib, we go for PET scan. Clear? And what is the gold standard investigation for recurrent GIST? Important point. Gold standard investigation. Gold standard investigation for recurrent GIST, we perform PET CT. Recurrent GIST, what we perform? PET CT. You know that investigation of choice for diagnosis, it is CCT. And for majority of recurrence, we do PET scan. So gold standard investigation for recurrent GIST, that is PET CT. There is a triad which is asked in relation to GIST, that is Carney's triad, and the components are multifocal GIST, pulmonary chondroma, and extra-adrenal paraganglioma. Next condition is infantile hypertrophic pyloric stenosis. Previously it was known as congenital hypertrophic pyloric stenosis, but you know that this is acquired. That's why the name has been changed. It is infantile hypertrophic pyloric stenosis or IHPS. What is the problem in IHPS? You can see it is characterized by hypertrophy of circular muscle fibers at pylorus. And because of this hypertrophy of circular muscle fibers at pylorus, there is obstruction. So this is acquired. How much is the incidence? Incidence, it is 1 in 3,000 to 4,000 live births. 1 in 3,000 to 4,000 live births. Here, child is normal at birth. What is the age of presentation? 4 to 6 weeks after birth. Age of presentation is 4 to 6 weeks after birth. And characteristic feature, usually it is seen that first-born males are commonly affected. It is going to affect mainly first-born males. Clear? What is the problem here? You can see in this case there is obstruction at pylorus. So patient is going to present after 4 to 6 weeks of birth. Means after breastfeeding, what will be the problem? Whatever the breast milk is going into stomach, yes, it is collected. And after that, what will happen? Patient will be having multiple episodes of vomiting. What kind of vomiting? Non-bilious. It can be projectile or non-projectile vomiting. So clinical features. What are the clinical features? There are multiple episodes of non-bilious vomiting, and this vomiting, it can be projectile or non-projectile. So multiple episodes of non-bilious vomiting, which can be projectile or non-projectile. One problem, projectile or non-projectile. Second, since obstruction is here, so what will happen? You are going to detect the peristalsis. And what is the direction of peristalsis? You can see here the direction of peristalsis will be from the proximal part to distal part. So direction obviously from left to right. So whenever you are performing the examination, you can see the visible peristalsis, and direction of peristalsis is from left to right. Third thing, if you perform the palpation, you can feel a mass. That is what? Palpable olive. So there is palpable olive or mass. So there is palpable olive or mass. Where you can feel this olive or mass, typically this olive or mass is felt in epigastrium and sometimes in right hypochondrium. So this palpable olive or mass, it is felt in most commonly in epigastrium. This was a question in latest exam. Epigastrium, or it's followed by right hypochondrium. Clear? So on the basis of clinical findings only, an experienced clinician can make the diagnosis. Experienced clinician can make the diagnosis on the basis of clinical findings only. But if we have to confirm the diagnosis, what is the investigation of choice for diagnosis? Investigation of choice for diagnosis, that is ultrasound. Investigation of choice for diagnosis, it is ultrasound. We can make the diagnosis on the basis of barium meal also. So if we perform barium meal, on the basis of barium meal also we can make the diagnosis on barium meal. And what are the findings or signs on barium meal? There is string sign on barium meal, string sign, shoulder sign, double track sign. So there is string sign, shoulder sign, and double track. What? Double track sign. Clear? If we perform X-ray, there is single bubble appearance. Single bubble appearance on X-ray. So this patient is having medical emergency. Why? Because the patient is having dyselectrolytemia. So what is the classical dyselectrolytemia here? What is there in gastric juice? You know that in gastric juice there is HCl and there is potassium. So gastric juice, it is rich in HCl and potassium. Because of multiple episodes of vomiting, there is loss of all these electrolytes. So patient will be having what? Hypokalemia. There is hypochloremia. And since reduced H plus means patient is having metabolic alkalosis. There is metabolic alkalosis. Clear? So what's the problem here? You can see there is hypokalemia, hypochloremia, metabolic alkalosis. Clear? When the kidney is going to sense metabolic alkalosis, what happens in the kidney? In the kidney, especially in the collecting duct, there is sodium proton exchanger. So this is the sodium proton exchanger. So whenever kidney senses metabolic alkalosis, kidney is going to preserve H plus, going to excrete sodium. But when sodium is excreted in urine, it takes too much of water also. So patient is having vomiting. Because of that, there is fluid loss, and patient is excreting sodium. Because of that, also fluid loss. So kidney senses severe hyponatremia and severe hypovolemia. And after that, what happens? Kidney reverses its function. Now kidney starts preserving sodium and starts excreting H plus. This is known as what? Paradoxical aciduria. So this is known as paradoxical aciduria. So what is the characteristic dyselectrolytemia? Hypokalemia, hypochloremia, metabolic alkalosis with paradoxical aciduria. So it's a medical emergency. That's why first we have to resuscitate the patient. Fluid resuscitation should be started. We have to correct the dyselectrolytemia. You tell me, what is the fluid of choice? What is the fluid of choice? So in gastric outlet obstruction as well as in hypertrophic pyloric stenosis, you have to remember the fluid of choice, it's normal saline. So here fluid of choice, it's normal saline. And what is the treatment of choice? We go for Ramstead Friedet pyloromyotomy. Name of surgery, this is Ramstead Friedet. So this is Ramstead Friedet pyloromyotomy. Clear? So Ramstead Friedet pyloromyotomy. Sometimes in exam you will get only Ramsted's operation. So treatment of choice is what? Ramsted's operation. It can be done by open approach also. It can be done by laparoscopic approach also. You can see this is trichobezoar, and what happens in trichobezoar? There is concretions of swallowed hair in GIT. Generally, it is seen in females who are having long hair. So it is more common in females who are having long hairs, more common in females having long hair. These females are having habit of eating their own hair. This is known as what? Trichophagia. So these females are having habit of trichophagia. Trichophagia. Clear? Trichobezoar is the most common type of bezoar in children. So this is the most common type of bezoar in children. Clear? You know that hairs are not digested. So hair ball, there is formation of hair ball in stomach, and because of formation of hair ball, what happens? There is obstruction in stomach. Also, it can causes what? It leads to, apart from obstruction, it leads to ulceration in stomach. So because of this ulceration, what? Patient is having abdominal pain. Initially, patient is having abdominal pain, and later it can cause what? Obstruction. So it causes gastric outlet obstruction. If you see this image, some of the females who are having long hair and the gastric trichobezoar, if it is extending to the duodenum, sometimes to the jejunum. So whenever the gastric trichobezoar is going to extend into duodenum, this is known as Rapunzel syndrome. You must be knowing the story of Rapunzel. So Rapunzel, who was having long hair, Rapunzel syndrome. Clear? Whenever there is gastric trichobezoar, there is gastric trichobezoar having extension up to the duodenum, sometimes into jejunum. Clear? That is Rapunzel syndrome. So what's the treatment? We have to perform the gastrotomy, and after performing gastrotomy, what you have to do? You have to remove this hair ball. So treatment, we perform gastrotomy, and after opening the stomach, we have to remove the hair ball with removal of hair ball. Clear? We discussed that this female is having what kind of habit? There is trichophagia. This habit is there. Patient is having the habit of trichophagia, means eating own hair. That's why we have to refer this patient to psychiatrist. After that, what? Psychiatric referral. So after surgical treatment, psychiatric referral is required in such patients. What is gastric volvulus? In gastric volvulus, there is torsion of stomach. What are the types? Two types. One is organoaxial and second is mesenteroaxial. Organoaxial means along the axis of organ. So organoaxial means along the longitudinal axis of stomach. This is along longitudinal axis of stomach. And mesenteroaxial, this is along vertical axis. So this is along vertical axis of stomach. So in this image, you can see this is the organoaxial along the longitudinal axis, and this is mesenteroaxial. This is mesenteroaxial. This is along the vertical axis of stomach. It is characterized by a triad. What? Borchardt triad. So specifically, which one? This organoaxial. It is characterized by a triad, and the name of that triad, it is Borchardt triad. Characterized by Borchardt triad. So specifically, this organoaxial type of gastric volvulus, it is associated with Borchardt triad. So because of twisting, there is pain, inability to vomit, and inability to put the rice tube. So this is Borchardt triad, which is associated with organoaxial volvulus. So this is all about stomach. Now we are going to start peritoneum. First of all, we are going to discuss peritonitis. So what are the types of peritonitis? Spontaneous bacterial peritonitis, secondary bacterial peritonitis, and peritonitis in CAPD, that is chronic ambulatory peritoneal dialysis. Okay. Question: what is the most common organism responsible for spontaneous bacterial peritonitis? So this is monomicrobial. This is monomicrobial. Infection is monomicrobial. In adults, the most common organism is E. coli, and in children, it is group A streptococci. So in adults, it is E. coli, and in children, it is group A streptococci. In children, this is group A streptococci. Group A streptococci. After that, secondary bacterial peritonitis, this is caused by visceral perforation, and that's why it is polymicrobial. Here, what are the organisms responsible? Aerobis E. coli and anaerobis Bacteroides fragilis. So secondary bacterial peritonitis, this is polymicrobial. Which organisms? Aerobe E. coli, because it's there in fecal matter, and anaerobe, that is Bacteroides fragilis. Bacteroides fragilis. Peritonitis in CAPD, chronic ambulatory peritoneal dialysis. So for that, you have to insert a peritoneal catheter. There is one organism which is going to colonize the implant's catheter processes. What is the name of this organism? Staph epidermidis. So peritonitis in CAPD, most common organism responsible, that is staph. Staph, which species? Epidermidis. It is the staph epidermidis. Clear? Most important is SBP, that is spontaneous bacterial peritonitis. We are going to discuss in detail. Now, what is the prerequisite in spontaneous bacterial peritonitis, which is also known as SBP? The prerequisite of this condition is ascites. So, patient should be having ascites. And there is spontaneous bacterial infection. What is the most common cause of ascites in adults? You know, the most common cause is cirrhosis or chronic liver disease. So, most common cause of ascites in adults, it is cirrhosis or chronic liver disease, and most common cause of ascites in children, that is nephrotic syndrome. This is nephrotic syndrome. Nephrotic syndrome. We already discussed the organism responsible. In adults, we discussed what is the most common organism responsible, that is E. coli, and in children, it is group A streptococci. Group A streptococci. Clear? And we discussed that this is what monomicrobial. Whenever patient develops peritonitis, patient is having pain all over the abdomen. There is tenderness all over the abdomen. Patient is having fever. Patient is having tachycardia. Now, how we are going to make the diagnosis? Since patient is having ascites and there is infection, we are going to tap the ascites, that is paracentesis. So, what is the diagnostic criteria on paracentesis? So, investigation of choice for diagnosis of SBP, that is paracentesis. We perform paracentesis. Clear? And whenever we are sending this ascitic fluid for examination, what is the diagnostic criteria? It's a question. So diagnostic criteria of SBP on paracentesis. First, we discussed that there is monomicrobial infection. So there is monomicrobial growth. And second, what should be the neutrophil count? More than 250. This is the diagnostic criteria. This is asked frequently. And how we are treating it? We have to give IV cefotaxime plus albumin. So what's the treatment? In the treatment, we give IV cefotaxime, and we give albumin. So we give IV cefotaxime plus albumin. Next is secondary bacterial peritonitis. It is secondary to visceral perforation. And whenever there is visceral perforation, what will happen? Fecal matter will enter into the peritoneal cavity. So the most common organism, it is E. coli and Bacteroides fragilis we discussed. This is polymicrobial. Bacteroides fragilis. So since it is perforation peritonitis diagnosed by chest x-ray, there will be gas under right dome of diaphragm. These patients are unstable at the time of presentation. So first you have to resuscitate, and after resuscitation we have to go for exploratory laparotomy. So what is the treatment here? Treatment. After resuscitation we go for first fluid resuscitation, and after fluid resuscitation we go for exploratory laparotomy. Exploratory laparotomy. And what should be done on exploratory laparotomy? First, we have to perform peritoneal lavage. We have to perform repair of perforation. And if there is huge or massive contamination, in that case, we have to go for stoma formation. So exploratory laparotomy plus we perform peritoneal lavage, and plus repair of perforation, if not possible or massive contamination is there, then stoma formation. We go for what? Stoma formation. And we already discussed peritonitis in chronic ambulatory peritoneal dialysis. There we insert a catheter, peritoneal catheter, and most common organism responsible, that is Staph epidermidis. And what is the treatment? Via catheter only we insert first generation cephalosporins. See this image. There are two important questions which are asked. First, what is the most dependent cavity in peritoneum whenever patient is in the lying down position or patient is in the recumbent position? So here you can see this patient is in the lying down or recumbent position, and what is the most dependent cavity? There are two important questions which are asked. What is the most dependent cavity in peritoneum when the patient is in supine or lying down position or in the recumbent position? So in this image you can see the most dependent cavity. This is hepatorenal recess, also known as hepato-Morrison pouch, also known as right subhepatic space. So in recumbent position or lying down position, most dependent cavity, that is hepato-Morrison pouch. This is hepato-Morrison pouch, also known as right subhepatic space. Right subhepatic space. Okay. Similarly, there is another question. What is the most dependent cavity in peritoneum in upright posture? And obviously in the upright posture, what? It's the pelvis. So in upright posture, it is pelvis. So here, in upright posture, it is pelvis. Clear? The same question is asked in surgery in some altered form. What? That what is the most common site of intraperitoneal abscess whenever patient is in the lying down position or patient is in the recumbent position? Same. Hepato-Morrison pouch. And most common site of intraperitoneal abscess when patient is ambulatory, means upright posture, pelvis. And overall most common site of intraperitoneal abscess, that is pelvis. So these are the questions which are asked frequently. Most common site of intraperitoneal abscess in recumbent or lying down position, that is hepato-Morrison pouch, also known as right subhepatic space. In upright posture, this is pelvis. And overall, most common site of intraperitoneal abscess, overall, this is pelvis. Overall, it is pelvis. Now see the mesenteric cyst, it is more common in females. And in which particular decade it is seen? It is seen in second decade. So more common in females, seen in second decade. What is the most common type? It is chylomlymphatic cyst. This is most common. And the second most common type, that is enterogenous. Enterogenous, this is second most common. Chylomlymphatic. So here, what kind of collection is there? Chylus. What kind of collection? There is chylus collection. And where is the abnormality? There is abnormality in lymphatics. So afferent lymphatic is there, but there is no efferent lymphatic. This is the afferent lymphatic. This is the efferent lymphatic. So there is no efferent lymphatic. That's why there is collection of chylus fluid. What is the good thing here? You can see that it is having its own blood supply. So there is no shared wall, no shared vascular supply. That's why here, what is the treatment of choice? Treatment of choice is enucleation. So here what we go for? Enucleation, because there is no shared wall, no shared vascular supply. So what we go for in chylomlymphatic cyst? We go for enucleation. That is the treatment of choice. But if you see enterogenous means the origin is from bowel. So in this image you can see this wall is shared. There is shared wall, and even if you can notice that this is shared vascular supply. So two things, there is shared wall and there is shared vascular supply. Here, what kind of content is there? Here, the content is mucinous. In enterogenous cyst, the content is mucinous. There is shared wall, shared vascular supply, and that's why what kind of treatment is done? Here you can see this kind of treatment is done. Clear? So what we have to do, we have to perform resection and anastomosis. So the part of bowel which is also involved, the part of bowel whose wall is shared, that is also resected. So here treatment is resection plus anastomosis. And in chyliolymphatic cyst, what is the treatment? Treatment of choice, that is enucleation. Simple. So in this image you can see this is the cyst and you can see it is mobile. Clear? It is moving perpendicular to the attachment of mesentery. This is the attachment of mesentery and it is moving perpendicular to attachment of mesentery. What is the name of this sign? This is known as Tilloch sign. So the name of this sign, this is Tilloch sign. When cyst is moving perpendicular to the attachment of mesentery. There is Tilloch's triad also. So what are the three components? First, there is soft fluctuant swelling in the periumbilical region. Swelling contain liquid. It contains liquid, that's why it's dull. But around the swelling there is bowel, that's why there is zone of hyperresonance. And third, it is moving perpendicular to attachment of mesentery. Name of this triad, Tilloch's triad. So the components of Tilloch's triad, first, there is soft fluctuant swelling in periumbilical region, zone of hyperresonance around the swelling, and swelling is moving perpendicular to the attachment of mesentery. Since it is extraluminal swelling in relation to GIT, that's why what is the investigation of choice for diagnosis? Investigation of choice for diagnosis, that is CCT. First investigation done, it is ultrasound. And treatment we already discussed. If it is chyliolymphatic cyst, we go for enucleation, and if it is enterogenous cyst, we go for resection and anastomosis. In both of these images, you can see that peritoneum is filled with this jelly-like substance. Peritoneum is filled with jelly-like substance, and what is the name of this condition? This is known as pseudomyxoma peritonei. So it is caused by mucinous adenocarcinoma, and when this mucinous adenocarcinoma is going to rupture, it is going to cause pseudomyxoma peritonei. What is the most common primary? The most common primary for pseudomyxoma peritonei, that is appendix followed by ovary. It is appendix followed by ovary. Idiopathic retroperitoneal fibrosis, it is known as Ormond's disease. What is the name? Ormond's disease. Idiopathic retroperitoneal fibrosis. Clear? So in retroperitoneal fibrosis, what are the structures which are involved mainly? There is involvement of ureter, involvement of IVC, involvement of aorta. So which one is most commonly involved? There is involvement of ureter. After that, there is involvement of IVC. After that, aorta. So most commonly involved structure, it is ureter. So two symptoms are there. Because of fibrosis, initially patient is having dull, aching, non-specific pain. Second, because of compression of ureter, patient is having obstructive uropathy. The most common specific earliest symptoms, these are symptoms of obstructive uropathy. These are because of symptoms of obstructive uropathy. Clear? So these are important points about retroperitoneal fibrosis, and this is all about peritoneum.